Saturday, and we're going to talk for just a minute. And well, I guess I should say welcome to our town hall, right? And I wanted to just tell you right at the very beginning, I don't know if anybody read our newsletter, and that's okay if you didn't, but I love to always put this slide in all of our presentations because I really believe that we are stronger together. And in our newsletter recently, I wasn't going to put it, but Holly read it and said, oh, you should, because it really fits what we're doing. And, we've had a lot of big news in our community lately, including the results of the Palvella phase 3 clinical trial, which admittedly were disappointing. And that's a lot of the reasons we're meeting today. We want this to know what's happening with that. But I wanted to tell you just a little story. At the beginning of May, my husband bought these little flowers, these little plants, and we put them, well, he did, he planted all over in our flower beds in our garden, thinking that we would have these flowers that would last all summer long and just beautify our yard. And we were so excited about them. But we'd never planted that type in our yard before. So we didn't know really quite what they were going to look like. And so we nurtured them, we watered them, we planted them where there would be good sunlight. And all through May, nothing happened. June, nothing happened. Most of July, nothing happened. And I was like, wow, this is kind of disappointing. We've just got these green stalks and they're growing, and maybe it's never going to happen. Maybe I'm never going to have these beautiful results of our efforts. And lo and behold, now the end of July, just almost overnight, oops, I'm going back. All of these beautiful flowers, it's like overnight, they just blossomed everywhere and they just took off. And I loved them and I was enjoying them so much. And then I was thinking about PC Project and with the results of the clinical trial. And I was like, oh, okay, this is giving me hope. Someday we're going to bloom. Someday it's going to be our time and we will get that. We will get a treatment for PC because that's what I thought blooming meant. And then as we continued on, we rallied and we continued on. I thought, Jan, that is wrong. That is wrong thinking. We are already blooming. We are already doing so many things right now. And we're going to have our little bit of our town hall right now. And I hope you can see just a little bit how we're blooming. But I just thought, man, we may not have a treatment yet, but look at us. Look at this amazing, strong community that is right here today gathering. And we're gonna just show some of the ways that we're already blooming. And so with that, I got to go back. I put my slides in the wrong way. Welcome officially to our blooming, sounds like a swear word almost, PC Town Hall. And this is the agenda. I'm going to give a little bit of the PC Project update. And then we're going to just a few things about what we've been up to. Then we're going to do a Palvella clinical trial update. And I'd like to welcome especially Dr. Dave Hansen and Dr. Adele O'Toole. Both of those doctors were PIs on the clinical trial, and many of you have probably had interactions with them through patient support meetings, both virtual and in person. And then we're going to open it up for discussions and questions. And we do have your questions that you submitted in advance. And if we don't answer them in the course of what we do, be sure and we'll try to make sure that we can. And we hope we have chances for you to unmute and talk if you'd like. And Holly is right here with me in the office, and she will be watching the chat as well and make sure we get all the questions answered. So with that, I just wanted to tell you, I'm not going to give every time we have one of these, there's always brand new people. And so I'm always like, what do I say? But just if you've never been on any kind of Zoom call or video meeting or presentation with me, I just wanted to let you know that the vision of PC Project has not changed. Our vision is still a day when those who suffer from PC will live without excruciating pain, sometimes isolation and embarrassment. So nothing's changed. Our vision has not changed. We are dedicated to finding effective treatments and a cure for PC, a painful, debilitating skin disorder. And you might have noticed we added that to our mission with our board of trustees last year, because too many people got caught up with what in the world is PC. So we put what PC is right in the middle of our mission statement. And we do this through helping and connecting patients like we're doing today, empowering research, and partnering with industry. So I'm just going to spend just a little bit of time talking about what we're doing with each one of those. Helping and connecting patients. I couldn't resist. This was our last in-person patient support meeting in New Orleans. And this is a wonderful group full of patients and scientists and doctors. So we have an amazing opportunities to connect sometimes. This is a little unusual. And I just thought, because I wanted to share something new. We always talk about our registry and why our registry is so important. But PC Project, when I say that, that is basically me and Holly, and we have a part-time bookkeeper, Joanne, and we have a part-time person that helps me with social media. And if you want to know what in the world we do all day, it is registry growth and maintenance. And that involves the patient intake, follow-up calls, photos, saliva kits getting mailed, follow-up calls, results reviewed, results reported, so many emails, calls, support and accommodation letters, ongoing help. We maintain and fund the website for the registry portal and keep our database HIPAA compliant. And what that means is it's very secure. And also we talk about keeping our IRB approved status. We can't just do a registry because we want to have one. We have very strict laws and regulations here in the United States about collecting data. And I just want you to know that PC Project is compliant in all of those ways to keep our registry right on board so that when you join the registry, your data is very well protected. We don't share anything without your permission. That said, well, I guess I should say identified data. We share and coordinate the use of de-identified data for research projects and publications. We also notify patients about relevant clinical trials, as you well know. We answer questions about studies, we coordinate studies. We also, as part of the registry, we provide opportunities for you to communicate with one another. We moderate the private Facebook chat. We organize and execute patient gatherings like this one. And of course, we communicate through social media, newsletters, and the website. And gosh, I'm trying to decide if I want to go to this, right? That, you know, I'm going to keep going. I want to take you for a spin on the website really quick, but let's just keep going. I want to show you on the growing registry. So just in the last 7 months, we have had 74 new patients who contacted PC Project, you know, for thinking they might have PC. Since the first of the year, we've sent out 47 saliva kits for genetic testing. Today, we have 2,695 patients in our database. 15, I'm like this, feel like I'm back in elementary school where I have to say numbers out loud. 1,525 are fully enrolled. That means they've completed the questionnaire, they've given us photos, and they have a genetic confirmation, but they don't all have PC. And just so you know, right now, 1,169 people are fully enrolled in our registry with PC. Now you notice there's a big gap in between there, but some of them don't have PC. And so there's, and then of course you can see there's a gap from this number. I don't know if you can see my cursor to this number. So there's a lot of people in between doing different steps. So I just thought maybe for the first time, I would let you guys know the registry, when we talk about the registry, it's alive, it's an active thing. Keeps us busy. That's a lot of patients that we look out for, but we love it and we're happy to do it. I just wanted to let you know that part of this registry, we are still diagnosing new patients. We are still teaching clinicians and scientists about PC. We are starting to become more attractive to pharmaceutical companies. And I always have to put in this plug. If you have not joined the registry, even if you know your PC type and mutation, because maybe you have a family member that has PC, please join the registry. And with that, I just thought you might want to see where we're at. This is literally yesterday's data. We have the most right now. K6A, K16 is second, K17 is third. We have the least in K6B and K6C, but we just got a whole family that just joined. We might really help the K6C numbers. And anyway, so that's kind of where we're at. I also wanted to let you know, one of the main reasons, well, there's a lot of reasons, but a big reason that we do genetic testing and believe so strongly in it. I just wanted to show you, you know, PC is a mutation in you probably know the PC types because you're on this call, you know about PC, but look at all these feet. And you can see all of these feet have come to us thinking they might have PC, but you notice there's some mutations there that you probably haven't recognized before. So about 2 years ago, we started testing on a bigger panel. We used to test on a 9 gene panel. Now we're testing on a 49 gene panel. And so we're picking up other mutations of diseases that are very like PC, but they're not. But I guess I wanted to say this for several reasons. One is we take care of those patients. And if some of you are on the patient chat, you'll see there's members in our community that don't necessarily have PC, but they might have one of these mutations, but they don't have anywhere to go. And so we say, stay with us. And in fact, we hope that there's maybe some molecular pathways. In fact, we know there's some diseases in our registry that have similarities to us that maybe if we get a treatment for PC, it might help some of these others. So just wanted to let you know, especially if you're observing that in our community right now. And it's just growing. It doesn't seem like a lot, but you remember PC Project started with 3 patients. So I just felt like as the PC community, you should know that we are gradually getting more and more patients in here too. But hey, we all got sore feet, right? So there we go. Second part of our mission is empowering research. And again, there's so much I could tell you. I deleted like 10 slides last night on this, but I just wanted to let you know, again, one of our major deals is the International PC Research Registry. It is huge for learning about PC. The second, I wanted to just let you know, we are funding grants. We funded earlier in January a $100,000 grant. And actually the end of August, we have a deadline and we are awarding $200,000 more in grant funding, at least for PC research projects this year. So we are funding. We haven't really advertised grant funding as much as we have this year because basically our board and me, I kind of laugh. I say, I'm tired. I want to accelerate things. And we know money drives research. And the more money we have to get people, nobody's going to care about us unless I shouldn't say that. Of course they care about us. In fact, that's the next point. We collaborate with researchers in our International PC Consortium to drive progress. And so we do that. We have so many people, even on this call today, that are just kind to us, that volunteer their time, that come to our symposiums, these researchers and doctors that care about us. And yet at the same time, people can't work for free. They can't run a lab. They can't hire somebody to do research in a lab without funding. And so that's why we want to award more grants than ever before. And so the more donations we get, the more grants we can fund, we get more people involved. And then one thing that we're actually doing, you probably have noticed that Holly and I are going to go to Washington, D.C. We're going to meet with the NIAMS, NIH people. We're going for a meeting, but we've been contacting the people over there who are the directors of the people that give grants for PC there. We're really working hard right now to establish relationships with them so that when someone submits a PC grant, that they'll go, oh, and so that it's kind of new for us, but we're trying to work on the empowering research in a lot of new ways this year. Let's see. Hey, hang on. I pushed my button and it didn't move. There it goes. Oh, this is just what I want to show you. You guys have seen this. You get the stuff. And what was I going to say? This was a picture of our last meeting. And if you wondered, oh, they had a nice visit to Japan. No, we went there because everybody in the world went to Japan in May. Everybody in the world who was part of the derm research world, maybe not everybody, but a lot of people. And we talked to our steering committee and they said, yep, we got to be there. And so we hosted, because of course people were coming there already, and we're cheap because we're a charity, people were coming already. And so we had our big consortium meeting right before them. And it was really great. I mean, it was robust science. It was great presentations, a lot of collaborations. We had some pharma companies in there with us as well. So it was just a great meeting. And that's the only slide I'm going to share about with that. I just wanted to I always like to reiterate that these two programs of PC projects are International PC Consortium, and that's made up of researchers, physicians, and now we're inviting industry or pharmaceutical companies to join in to listen and to learn from our experts. And then, of course, our registry, and that is you, and that is your data as well. But the fact, I mean, we cannot run clinical trials without you. In fact, I'm going to get to the last part about networking with industry, partnering with industry. And I was like, oh, what picture do I show for that? And I just wanted to show this cute picture. This was some people that participated in one of the Palvella trial. They had like an event, and I won't go into what they did, but they sent me pictures, and they're kind of representative of all of you who have been participating in trials. And I know it doesn't work for everybody. I also know that there are certain places in the world where not everybody can participate in a trial, but to those that can and are available to, I just want to express my really sincere gratitude for you guys who are able and who can to do this. And with that, I wanted to just give you a little quick sum up to let you know some of the things that are happening. So clinical trials to evaluate potential, and I always have to say potential treatments for PC. And first of all, Dr. Hovnanian is going to do an off-label study of a treatment in France. He's actually been fabulous. He did a lot of preliminary preclinical work to see if this drug would be helpful in PC. He's done a few case studies, and now he's getting ready to design he is in the process of designing a clinical trial to test this drug and see what it's going to do for PC, because the results have been looking pretty good. We've got a phase 1 in Israel, and we've got Kamari Pharma phase 1 in the UK. And then of course, phase 1, that's just where they're figuring out safety, and they're figuring out maybe a little efficacy, but I think the main thing is safety. And so if any of you on this call are in the Sol-Gel or the Kamari Pharma trial, thank you. And if things look good, we'll get bigger trials for that. The phase 3 is what we're going to talk about next. But I just wanted to stop really fast before I hand it over to Adele and to Dave. And I'm just going to go really super fast. I know the time's going fast. I always say I'm not going to take very long, and I took a long time. Has everybody seen I just wanted to just show you, because I can't show you everything. Has everybody seen our wonderful brand new website that went live in, I can't remember if it was March or April. I just want to make sure before I pass it over, before this day is over, everybody knows how cool our new website is. I just want to point you out to just a couple of things. We have a brand new, well, kind of brand new, we took from the old, and we've got a new managing and caring for PC section. Best practices is shared by the global community. So there's a lot of good best practices right in here. But the next thing I just wanted to make sure you knew on here, this is so cool. This is literally from you guys. This is anything you want to know about what's going on in caring for PC. And I won't take the time, and a big shout out to Holly and Shrikant, who really did an amazing job putting this together for us. And, you guys share things with us. You email us ideas. You also put things in the patient chat. We look at it, and we've got doctor tips in here too. So just keep in mind, if you ever have questions, definitely go to the patient chat, because that's great. That's live information. But don't forget to come here too. I also wanted to show you one other thing. Well, I keep saying that, news. Look, if you want to know what's going on, you don't want to wait for the newsletter, just come here. You're going to see all this. Just goes on, and it's awesome. You can also go see our events. You can see everything that's happening. And if you click on one, look, the Quinoa Festival's coming up. Hey, if you live in Utah, come see us in Bryce Canyon. So just wanted to make sure everybody was aware of this. Last thing, because I'm going to segue now to Dr. O'Toole and Dr. Hansen. If you ever want to know what's going on in clinical trials, you can go here too. Oh, I keep saying it. One more thing. It's under professionals. Go under professionals. It's okay. And if you ever wanted to find a published research article about PC, you can search it here as well. So I just invite all of you to just enjoy the website. There's just so much good information on there. And with that, I am going to turn now that we're back to clinical trials. Sorry, Dave and Adele. I'm going to pass it over to you, and I can share my screen for you if you like, but we're going to get a little just casual from here on out. And I don't know, Dave, do you want to go first, or Adele? I guess you guys can do it however you want. But I've got this slide up. I don't know if you want to review it, but we'll go through that slide if you want. And then from there, I'm going to just let you two take it over. Does that sound okay?
So, Jen, you can hear me okay?
I can hear you great.
Perfect. Okay. I thought maybe I would try and do a little bit of background and then let Dr. O'Toole talk specifically about the most recent clinical trial with Palvella.
Should I stop sharing my screen for a minute?
You can
keep it there. It's handy to have it.
Exactly. I would keep it there, and we'll just talk over the thing right there, so that I'll do some background. What I wanted most people on the call to understand is what happens and why a clinical trial is done. For years, we've had ideas about what might help PC, and so we would try this and try that. And even if it seems to work, you can't market that as a treatment for PC without having the Food and Drug Administration in the United States, called the FDA, approval that the medication is both safe and effective. And so the purpose of a clinical trial is to demonstrate that the proposed treatment you're giving to individuals is both safe, so it doesn't cause other complications or problems, and it's also effective, which means that it works well enough that when you compare it to no treatment at all, it makes a significant improvement. When you satisfy that those two elements, then you can submit that to the FDA for approval, and it can be marketed as a treatment for that particular disease. To give Palvella credit for some things that took place, this was the first true clinical trial we had done. We have done some small pilot studies before, but Palvella was the first one that sort of showed us what it took to actually get a medication approved for PC. And it really opened the door for us to say, here's where we need to go in the future to find an effective treatment. But they were an excellent group in terms of they had some of the world's experts in terms of delivery systems. That is to say, you put a medication in a cream and make sure that the cream is safe, and also that the medication penetrates into the skin, so it makes a change. We had to design some type of a measuring of what we call an endpoint. So when you do something, you have to actually take and show that you can have an endpoint, and that endpoint improves while they're on treatment. And so an endpoint is just the demonstration that the medication actually works. Along with that, you have to be certain that you do blood tests, you do other kinds of things to be sure that there are no changes internally as a result of the medication that could harm the patients. And so that Palvella was wonderful in showing us how we can do this and how it works. We were disappointed in the final result of this last clinical trial, but the process of getting that has really opened the door for us to find effective treatments for PC. And Dr. O'Toole, do you want to talk a little bit about this particular trial?
Yeah, okay. So in the trial, there were a total of 82 patients. 27 were recruited in the UK, and the remainder were in the United States at various sites throughout the States. And basically, after quite a lot of work by Palvella and various dermatologists who are interested in PC, and the FDA, it was decided to use this patient global assessment of activities difficulty as the primary endpoint. So that's a patient-reported outcome. And basically what they did was they compared the first 2 weeks of the trial on drug with the last 2 weeks of the trial. And the patients had a 4-week screening introduction before they started the drug. And the idea of the screening was that they would get accustomed to the to reporting this patient-reported outcome. So we had to check their numbers and, you know, make sure that we thought they were doing it right. One of the things about placebo-controlled trials where pain is involved is that there's a really high bar. So it's actually quite hard to prove that something is better than placebo, unless there's like a really major effect. And one thing I would say about the topical rapamycin was that when you looked at the patient's feet before and after the study, it didn't look like there was a very big change, although many patients reported that they felt better on their feet or they felt less pain. And some patients reported that they were paring down the callus less. However, when there is an outcome like this, and the outcome here is basically that there isn't any difference, then the company decided that we cannot progress with this. So they had planned to have a safety study and continue treatment, but because of the outcome of the trial, it would be unethical basically to proceed. So it's always important to have a placebo because something called the placebo effect. And it's estimated that the placebo effect in this trial was probably about 30%. So that means that 30% of people who were on placebo thought they were better. And this is a well-known thing in pain trials. So for example, in migraine, if you have a trial for migraine, 50% of people, if you give them placebo, will think they're better. So you know, all because you have PC, you obviously have pain in your feet all the time. So I'm sure anybody who participated in the trial has a feeling of frustration to a degree, but it's all progress on making better trials for PC, basically. I mean, the information that's being gained from this trial will help with the design of the next trial. So I think that's something positive.
We were all disappointed in the results because patients, for the most part, felt like they had improved on the treatment. And we have some evidence from the laboratory that rapamycin alters some features of PC that should make it better. What Dr. O'Toole mentioned was that we expected that we would see some improvement in calluses as well as nail changes, but we didn't see those. And then when we did the evaluation of the study, there was no difference in the placebo and the treatment group, which you need to have a difference to prove efficacy or to prove improvement from the medication. So we were disappointed, but the trial was very helpful.
Thank you. I want to just make sure I got all the questions here. So the question was about the clinical trial and why it was stopped. I think we've answered that. It was stopped because it's just not ethical to continue with a treatment, right, Adele? I heard you say that, and yes. That's true. And also money-wise. Oh, go ahead.
So Jan, that's not to say that some other mTOR formulation might not be better. So rapamycin is an mTOR inhibitor. And there is another company, Biomendix, who is developing an mTOR inhibitor, which is different to rapamycin. And they may want to trial it in pachyonychia congenita.
Yes, that's a good thought. I didn't even have those. They're not even on our website yet. I'm laughing. We're on their website, actually. They are doing, this is a perfect example of how our consortium, our consortium of researchers and scientists work. They have been given PC cell lines and they are testing their drug, their mTOR inhibitor, if you will, right now to see if they think they have enough preclinical data to move it into a clinical trial. So, and that's not even, like I said, I haven't shared that with anybody. You guys are the first to know because it might fail. I mean, we don't know, but they're going to try it. So there's lots of still possibilities. Okay. someone who mentioned, I'm so saddened by the results of the clinical trial. I really felt my feet improved while on the open label drug. What would you say to the people who felt sad? And anybody that wants to make a comment or raise their hand, let me know. But what would you say to people that felt like they improved?
You want to go first, Dave?
Go ahead, Adele.
So they may be experiencing placebo effect. They may be experiencing effective drug because obviously if they were in the open label study, they've already had drug. So we know that topical rapamycin actually stays in the callus for 4 months. So there isn't, huge turnover of topical rapamycin inside the callus. Okay, you're shaving it down, but at the bottom of the callus, there probably is still some topical rapamycin for quite a while. So it probably does take a while to get going. And it may be that, you are experiencing some effect from the drug. I guess one thing I would ask is, did you notice any change in the callus? Did the callus go away or improve a lot? Or do you think the callus is still the same? Does it look the same?
Thank you. What about potentially getting it off label? I'm just reading questions here. Is there a potential if that drug ever comes to pass about obtaining it off label? Is that a possibility for patients someday?
I think if it's licensed as a treatment, yes. So in the UK, certainly, if something becomes licensed, you can apply for permission to prescribe it for people.
Thank you.
Maybe England might say no, but you can ask.
But it's what's called off-label use, and that happens with some medications that are used off-label. But it's something then the physician has to take responsibility for the outcome. It's not something where it's been shown to be effective or safe.
Okay, great. You know what? I think that's probably good. I think you guys, I'm looking at the questions and I think you guys probably covered those. There's 2 in the chat. Okay, let me just look really quickly at, I want to make sure it's so no difference between placebo and other. One thing I've talked to Palvella at length about this. I mean, one thing is they've wondered, and I want to, maybe I better be careful, but the vehicle might have had the vehicle, the actual formulation that the drug was put in, maybe that had some really nice properties. Maybe that, it was very well designed. It was an elegant formulation. And again, I'm spinning, so I probably shouldn't speculate at all here. But just that was the thought that, maybe the vehicle, itself did something and was helpful. We kind of tease, Holly and I said, well, let's just market that as a cream or a gel off label, off the market, and we'll just buy it that way. So just a lot of things we don't know. They'll continue to slice and dice the data, look at things and see what can happen. But as far as we go as far as we're concerned right now in PC Project, that is gone, that ship has sailed. However, even literally just yesterday, the CEO of Palvella sent me a list of things that our group should look and see. You, Adele and Dave, and I don't even know about it yet, but send me a list of things that they have learned already from that they want to give us for advice for future clinical trials. And, they want to share, they want us to succeed. They care very much about us. And so I just reiterate what Dr. Hansen and Dr. O'Toole said. We have learned so much. And so it's really important to me that everybody on this call knows, who participated and even who didn't, that what we did is not in vain. Clinical trials fell. In fact, if you look up the percentage, they fell a lot. But that said, nothing gets passed without a clinical trial. So we have to keep doing those. And it's great when it's something easy and it's safe. I want to just make sure I got everything covered. So yeah, we're moving on. I guess that's the way of saying it. I'm going to stop sharing the screen now. And I just want to see about questions in the chat. What am I seeing? Oh. Oh, Adele is all over the chat. Okay, great.
Yes.
Thank you, Adele, for being
Hi.
all over the chat and answering questions in the chat. I just want to look at any of the other questions. At 74 years old, this is from one of our people here. Do you see a treatment for PC in the next 10 years? Ooh, and anybody can answer on if you're a doctor on this call. Do you see a treatment for PC in the next 10 years? This person is wondering, I'm 74, do I have hope?
Yeah, I think so, for sure.
And
There are so many things. There are so many things being tried. Something is going to work.
In the last 3 years, since Palvella started this, there's amazing the number of ideas that have come through understanding what drives the inflammation in the skin that creates the pain. And so I don't think there's any question but what we're going to find something that seems to work if we can prove that it's safe to use with patients. We're very close.
Somebody asked, what is the status of investigations of topical erlotinib or other EGFR pathway inhibitors? Wow. I don't know if Dr. Hovnanian's, I know he's on the call, but I don't know if he's working while we're talking. That's kind of a loaded question right there, because everybody on this call knows what an EGFR inhibitor is, right?
Well, to answer this question about topical erlotinib, I think Palvella is currently working on it using the Q-Taurine formulation and putting erlotinib in it. But I don't know the advance of, I mean, in which stage they are. That's to answer the question on topical erlotinib.
And I should add real quick, sorry to interrupt, Sol-Gel is also pursuing that as well. That's what Sol-Gel's drug is. It's a topical erlotinib. So you can go to our website and look that up. In fact, it was in our newsletter 3 days ago. But go ahead, Dr. Hovnanian. You have more to say, I know.
And if the other part of the question refers to oral erlotinib, as you may know, we treated off-label 3 adult patients, and they responded very well. The pain significantly improved very quickly. Also, the callusis remained quite the same for a very long period. Also, they were softer, less painful, and thinner. But the major effect is on pain. But there are side effects like acne-like eruptions on the face or the trunk, transient hair loss, but they regrow, some diarrhea, but which is minor, and that's it. So this is excuse me.
The chap I had on it developed a very red eye, but it got better.
Yeah,
got better.
So because the results were encouraging, we are writing a project for a clinical trial to try to treat 20 patients. It would be a placebo-controlled trial, and this is what we are working on at the moment.
Fantastic. Thank you very much. I think this next one is going to be for Dr. O'Toole. Is any research planned into the treatment of steatocystomas? Yeah.
So I'm actually doing some research on steatocystomas. I got funding last year from an organization called the Leo Foundation, which is associated with Leo Pharma, but it's an independent charity, which is philanthropic. And we're doing, basically we're doing something called spatial transcriptomics, where we look in detail at what genes are expressed in the cells and the cells around the cyst, basically, and try and find out more about, the pathways involved and if they can be targeted. And so far, we've had one interesting finding. We basically found that the cyst seems to start in the keratinocytes, so in the very upper part of the skin. So I've got a student who's going to take biopsies of very early steatocystomas so that we can see if we can find what pathways are involved to stop them getting bigger, basically.
Fantastic, thank you. And I think for all of you here who have K17, I know that cysts are, you know, a very debilitating part of your life. Just know that we care about that aspect of PC. In fact, you know, the winners of the cysts are the K17 patients, but we also know that K6Bs seem to have them a little more frequently, and then K6As. And so cysts are part of a lot of our lives, and they're so fun, aren't they? So that's great. Another question. Are we okay to just keep answering questions for a minute here?
Jan, on that same question, two things. One, there was a question about follicular hyperkeratosis, and that's commonly seen particularly in young PC individuals. So before puberty, and so they'll get these little hard bumps around their knees, around the waist. That seems to improve with time. So you see it much more common in younger individuals than you do those over age 20. And so there's something happens in the terms of the maturation of the skin that seems to disappear. On the other hand, the cysts seem to develop at puberty and then seem to persist after that time. And there seems to be at least a hormonal component or hormonal relationship with the development of the cysts. And that's something that's of interest that we're running to look at as far as future studies on cysts go.
Excellent, thank you. And in the meantime, do you have any recommendations for treatment of cysts? When someone gets a bad cyst, what do they do?
Usually you try and drain that, and you can use medication to reduce the number of cysts and also to reduce the inflammation. We'll often use something called intralesional steroid or intralesional cortisone to reduce inflammation. But then I'll often suggest people use a topical antibiotic in the area where the cysts develop, because it seems to reduce the number of new cysts. And this is part of what you do for hidradenitis as well. Now, there's some more aggressive medications for hidradenitis that also seem to be helpful, but we have not used those specifically in PC patients.
Well, that's an interesting thing, because that was one of the questions about how to handle I call it HS, but the hidradenitis suppurativa in PC. And one of the questions is, what is the incidence of HS in PC patients? This person said, my son has been suffering with HS along with PC for the last 3 years.
I think the study that Ellie Sprecher did in Israel from the PC registry data, so patient-reported data. So the patients were shown pictures of what typical hidradenitis looked like. They were given a description of the typical symptoms and then asked to, tick box whether they thought they had it or not. I think 8% of patients with PC had hidradenitis, and that was about 40% in PC keratin 17.
Okay. So that's perfect. What is considered a mild form of PC?
I mean, I think if somebody comes to me and says they can run and stuff like that, I think is probably mild. But I don't think PC keratin 6C, for example, is mild.
No.
Patients can have a lot of pain.
But they often seem to have less nail disease, so they often have no fingernail involvement, but just toenail. And the calluses may be not as large or as painful in mild PC, but it's a misnomer to say all K6Cs are mild and all K6As are bad. You can't make that correlation.
That is really true. That is so true. And we see that, we talk about that all the time in our patient support meetings, and even on that private chat in the Facebook group. We just can't compare, because there are people that can walk and there are other people that can hardly walk at all. And we see such the spectrum, even across the 5 different PC types. And I think sometimes people say that K17 it doesn't hurt as much to walk. Well, that might be the case, but I just got an email from somebody yesterday that just said life is so hard for her feet, and she has K17. So there's just, we hate to peg everybody in one corner. So another question, what are some of the signs and symptoms seen in infants and toddlers that can provide some indication of the severity of the disease? This is almost a patient chat question. What are some signs that can tell you with a young child if the disease is going to be bad?
In most infants and so forth, the first change that we see is nail change. So you'll see toenails usually that will become discolored and then gradually thickened. And that seems to precede the callus formation and also the pain. And so the first thing we look for are nail changes. And they're often not absolutely specific, but if there's a family history, they're very helpful in identifying those individuals.
Thank you. Okay, let's see. Does PC affect the bone structure if damaged? And can it be linked to degenerative, these are big words for me, degenerative arthritis?
Adele, you want to take that one?
All right.
Does it affect the bone structure?
So I guess in patients with severe PC, or patients who have a lot of pain, if they walk, for example, unevenly on their feet, which some people do, like they might walk more on the right foot than the left, that can put strain on knees and hips and back, and then as an outcome of that, eventually get degenerative joint disease, maybe earlier than somebody who didn't have a problem walking on their feet. I have seen some patients get toe deformities, i.e. toes, climbing on top of each other, or toes sort of going the wrong way, because of, severe callus around the toes in PC. That does happen, but it isn't anything to do with, the bone isn't abnormal. It's just that the callus is pushing the toe in a certain way. Sort of like ladies who wear very high heels with pointy toes and then get a bunion. But in the case of PC, obviously, you're not wearing pointy toes with high heels, but it's your callus, unfortunately.
And just as a corollary to that, I don't know of any evidence that PC specifically creates bone changes.
No,
it would be secondary to the pain and the changes in the way you ambulate or the way you move.
That might be an interesting thing to study sometime. We spend so much time trying to work on the real, the research things, but this is kind of an interesting thing because it is a topic that has come up in our private chat before, people who compensate for the way they walk and then their hips start hurting or, things like that. So if you have any comments, put them in the chat. We'd love to know if you have some comments about that. If you feel like your hips or your knees are sore. I know for me, because I'm 55, I can't remember. I don't know how old I am, but I'm about 55, and I've crawled my whole life, and so my knees are just bone on bone. If I bend them, I'm bending it right now, I can hear a scrape. It's just. So I don't know what that's going to mean for me in 10 more years, but it's, there's definitely things that we do as PCers to compensate. Okay, I'm going to keep going. We still have some questions. Is everybody okay with these questions? Mm-hmm. Oh man. Suggestions for treatment of calluses on the feet or preventing new ones. Is that even possible to prevent new ones? This is almost a chat question, isn't it?
Exactly.
Okay. Oh, Jasper, I see yours. Actually, that was the next question right here, literally on my list. Is there an active research on foot grafting to replace affected areas with good skin in the feet? So this is a question we've had other people ask us in the past. Any recommendations or thoughts on grafting to get rid of those yucky feet and get some fresh ones through skin grafts? We have not done this in our community, Jasper, to my knowledge. Do the experts, any of the experts on this call have any thoughts?
Yeah, I mean, I've seen a couple of patients who've had skin grafts. So I've seen a patient with Olmsted syndrome, which is similar to PC, a lot of plantar pain, who had his whole feet grafted, and most of his hands, particularly on the fingers. And I've seen one patient with PC who's had grafting in the UK. I would say it wasn't a spectacular success. She still has quite a lot of callus, which regrows around the grafts as well. And I also had an experience of seeing a patient who decided to have his feet lasered. So he had all the calluses lasered from his feet. And he was in severe pain and was in a wheelchair for 6 months. This was someone who previously walked.
So that was actually literally the next question. We had 2 people write in and ask about lasering the calluses.
I don't think it's a good idea.
And I would second that. I think it's a bad idea. And all you do with the laser is you vaporize the skin. And so you remove that thick skin, but it doesn't change the underlying pathogenesis or the underlying thing that causes a callus to form. And so you go through the misery of having that callus removed with a laser without any real hope for long-term success, because it doesn't change the underlying condition itself.
Thank you. I think that's important. You know, I think all of us who have PC know when you trim your calluses down, there's not beautiful pink, wonderful skin or brown skin or whatever color your skin is. There's not that beautiful baby skin underneath the calluses. It's just, I don't know what it is, stuff. I call it raw hamburger meat. It's just nothing. So that what you're telling me makes very logical sense to me. So don't laser your calluses unless you want to be in a wheelchair for 6 months. Is that what I'm hearing? So just be careful. I think there's a few others. I'm just looking at the time. Any comments on pain relief? What can we do? It always comes up. Is there any thoughts for pain relief for PC patients?
Dr. Hanson, it's your turn.
Oh. Give me the question again, Jen.
Well, we just have we have a bunch on. Do you got any ideas for pain relief?
Goodness. Lots of ideas, but nothing that's been very well studied. There's lots of medications taken by mouth. Gabapentin is one that has been suggested that modify pain. There's also some topical, something called ketamine and amitriptyline, which are things used in neuropathies and pain and tingling and so forth in lower extremities. And so these have been suggested and have actually been used in some patients. Some people thought they were helpful. Other people, at least they did not produce enough improvement to say, boy, this is a great treatment for pain. Mm-hmm. So nothing really new.
Some people take pregabalin, which is sort of like gabapentin.
Gabapentin, yeah, it's a second generation.
Yeah, and some people take nortriptyline, which is sort of like amitriptyline, but it also has an effect on blood vessels. Mm-hmm. Can make you quite sleepy though, so people generally start on a low dose. The other thing about these pills is they take quite a while to work, so sometimes you have to take them for 4 to 6 months to see good effect, I think.
Thank you. These are questions that everybody could probably unmute and have a great conversation about, because I think there's a lot of tips and tricks even probably in this community of what we can do. There was a question about insoles. And again, I'm just going to refer you to the website. And well, we got El Bravo right here on the call. Do you want to say anything about insoles, Al? Yeah, Al is a podiatrist. He has PC and he's a podiatrist. He probably has amazing shoes.
I do have pretty amazing shoes. I think that as far as the pain relief is concerned, one of the most effective things for me, I have K6B and so does a number of my family members, is modifying the pressures that go on the foot. And if you're able to reduce the pressure with various types of insoles, and there's a whole bunch of different ones. I think we've written some stuff for the PC website previously. It's probably still on there. I haven't checked it lately, but I think that there are a lot of insoles that can be pretty helpful. There's a lot of newer shoes that can be pretty helpful in redistributing pressure off the typical hot spots. I think what Dave and Adele alluded to is super important to keep in mind, that just shaving away the calluses to the point of oblivion is not really a good solution. I think it's more effective than that would be to use the proper type of insole and shoe combination to reduce the pressures that are causing those lesions to start with. So there's a lot of different ones. They really kind of need to be tailored to the patient's individual foot structure and their size, you know, how their foot functions and gait, but there are a lot of different options available. And I know I've spoken to a number of the people who are on the call here about that individually in the past. I'm always happy to do that if anybody has questions.
Thank you, Al. Appreciate that. I'm looking at the time. I want to be conscious of our, especially our experts here. I want to get to Claudio's. Thank you for doing that. I totally skipped that question on my list, and I have it on my list. What are the prospects of genome editing like CRISPR-Cas gene editing to treat PC? And it says in similar diseases, but we all want to know about PC and this, well, Olmsted, some of these others that yeah. What are some thoughts? Do you guys have some thoughts about what's going on?
Let me say one thing about, for a number of years, we've looked at trying to develop something called siRNAs, which are small inhibitory snippets of RNA that you can put into a cell, and it blocks the abnormal RNA that's produced by the genetic change in the skin. And so there's a lot of enthusiasm, but it's been a difficult thing to try and actually make that work clinically. And so that there are some individuals, some laboratories that are working on that possibility of producing a small inhibitory RNA and getting it topically into the skin. But it's still very much in the research stage at this point. And Adele, talk about CRISPR.
Yeah, so the same would apply to gene editing. So there's sort of two types of gene editing broadly. There is CRISPR-Cas9, which is where you use sort of a genetic scissors to take out a bit of DNA. And then there's something called base editing, which is more sort of straightforward. And it's usually used just to change one single little piece of DNA. The issue with gene editing is that in theory, it's easy to do with cells in the lab. It's not that hard to do. But the issue then is giving it back to the patient. So, do you remove the callus and put it back on? Or do you just apply it in a cream and hope it gets down to the bottom of the callus and makes new cells that are normal? So, there are a huge amount of questions to be answered. So I think at the moment for PC, the most likely treatment is one of these kinase inhibitors. So for example, erlotinib looks promising. There might be a better mTOR inhibitor. There might be a good formulation of topical erlotinib, which will work for some people. And then there are there's a company called Camari who have a topical TRPV3 inhibitor. So TRPV3 seems to be very important in pain in the skin, but it might also be important in how the callus develops. So that's promising. Camari also are developing an oral preparation of their TRPV3 antagonist. So there's probably going to be a menu of options eventually, hopefully.
Yes, that's what we hope. For what it's worth, at our last meeting in Japan, we did have somebody that came and talked to us about the CRISPR-Cas that they are doing in their lab right this minute. and another person that was doing gene editing for another similar rare disease. And, you know, so we're, as PC Project, we want to stay up on that. We want to, we've got people, we know of people that are doing the work. We've got people in our consortium that are looking at that. But, you know, like they said, it's a big leap to be in the little clinic, the lab, and actually getting into patients and what that even does to patients. But we're definitely there. I'm just looking, oh my goodness, the questions keep coming. How are we doing? Is everybody okay? I mean, we can wrap it up, but I just want to see, I guess there's two questions that are kind of the same thing. Are there practicing dermatologists in the United States, or I guess we could even see around the world, that know about PC? And yeah, most doctors I visit don't have any awareness of this disease. I have to bring documentation, but they are fully interested in they are probably not interested in understanding, because it says, unfortunately, we just tell you patients over and over, this is the tricky thing. We're just too rare. I wish everybody, I live really close to Dr. Hansen. I'm super blessed. He's my doctor. How wonderful to have Dr. Hansen right here. I mean, wouldn't it be great if we all live next to Dr. O'Toole or Dr. Hovnanian? That would be awesome, but that's not realistic. And so there aren't very many people that know about PC. You know, if you've looked at our news site, or excuse me, our news, you'll see we're trying to increase that awareness. In fact, we just barely got we found out we're going to be published in a dermatology nurse publication. And so we're trying to make awareness. We're trying to spread awareness, but at the end of the day, unfortunately, every patient, especially when you move to a new place or you're trying to find a doctor, we just encourage you to find that doctor who's nice, who will listen, who will look at your genetic testing reports, who will look at a PC brochure, and then from there, be able to learn and listen from you. That's kind of the key right there. So that's kind of what we're at. So educate your doctors, and then they'll become a PC expert. And we don't have a list right this minute, but we've thought about doing that, having that. We're starting to collect names of doctors. And so we can, it's a goal to have it up where we can say, oh, if you go to London, you can go to Adele O'Toole and put her on the map because she's so behind. Ha ha ha. And do you guys have any questions on that or thoughts on there? And Kareem, I've got your comments too, and I'll get you there. Well, maybe I'll just ask, I think, okay, can I just ask one more question? This is about ear pain. A lot of the young kids with PC get this horrific ear pain. I'm looking at Birgit Lane. She's one of our great researchers too. I think she first is the one who identified it as first bite syndrome. Was that you? I can't remember, Birgit. But what do we do about these kids? This one in particular, she's 7 years old. K6A has intensive earache when she gets angry, when she eats, when she's going to cry. She also has a lot of ear serum. Is there anything that can be done to help this little girl in her pain? And this is a question that happens with a lot of our patients too. Any recommendations, doctors? Or so patients?
Has she been to see an ENT doctor?
That's a good question. See an ENT?
A pediatric ENT doctor, I think, probably would be a good place to start.
Okay.
With sort of, bring your patient information with you, that it can be associated with PC, but it sounds like if she's got fluid in her ear, there might be other things going on.
Okay. That's a good idea. ENT, an ear, nose, throat doctor.
Yeah.
And I can talk to you directly too afterwards. Yeah, we have seen the same issue, and seen an ENT. They have no idea about the pain. It's a really, oh, look, an adult. I see an ENT every 6 months to clean my ear. I know I'm a K6A, and I got the ear pain so bad when I was a child. My ear, it went back. I would pull on it. It only got it in my left ear. And every time I took a first bite or a drink or something that triggered it, I would just pull on my ear, and I would count about 20 seconds, and then it would kind of subside. My ear used to go clear down to here because I pulled on it so much. I could pull, you know, that, do your ears hang low? Do they wobble through my throat? I could sing that song really well because I could pull my ear. Unfortunately, there was nothing, and my 2 kids with PC have it too, or had it. The best news about the ear pain is for a lot of us, it subsides as you get older, but that doesn't help a poor 7-year-old who's dealing with pain. So unfortunately, there's not a lot we know about PC, but we do know. We were on the chat the other day and somebody talked about it. And I was like, wow, I thought it was just K6As, but it sounds like there's plenty of them, other mutations that are experiencing this ear pain. So it's just another corner of PC we don't know a lot about still. Okay, well, with that, wow, that was a full hour and then some. Yeah, keep the comments coming. I am happy to stay on and talk to anybody that has any questions or comments afterwards for a little bit. But if anybody needs to get off, it's fine. Well, I'll say we'll officially close our meeting. I'll say that we'll officially close it. And just wanted to tell everyone here, thank you. I appreciate, I think it was Michelle or Donna, I can't remember, that said earlier in the chat, I appreciate that you feel like you still have hope. And I want you guys to know that. I will admit, when I got the news about the Palvella trial, and Palvella had a lot of hope because we were seeing patients do amazing things. And we truly were getting ready for the next level with that. Didn't work, it failed, it's okay. And I was like, but you know what? For all of you that expressed emails to me, said, hey, it's okay, we're going to keep going. I just want to tell you thank you, because we are not giving up. I know we didn't go into a lot of depth on some of the things that are happening. Go to our website. We really try to keep it updated. I can't always put everything on there at first because sometimes we sign non-disclosure agreements. So we know things that are happening, but we can't always tell you what's happening. But trust me, we are still working hard. We are still here. That's why I want to show you the registry thing at the beginning. Trust me, we are not watching Netflix yet. We wish we were, but we're not. We're still having a good time, and lots is happening. And I just wanted to also say too, thank you too for your support. I don't even know if she's on this call, but you know, during June Awareness Month, there was a person, this was hilarious. She donated $25 every day during June Awareness Month. In fact, after the first couple, we were like, is the system broken? Is something happening? And yet she just wanted to show every day of the month of June that she was supporting PC Project and what we were doing. And I'll tell you, $5 once a year means a lot to me, because I know everybody's, I'm not trying to ask for money. I'm just saying, you saw it costs money to run things. Each genetic test is approximately, for PC Project, about $1,000. So it's not like 23andMe. By the time, you know, or Ancestry.com, looking for diagnostic genetic testing is much more complex, and, you know, trying to find a mutation. And so I just really appreciate the support that each of you give us. But I think, you know, having a genetically confirmed patient registry is critical for us to get pharmaceuticals interested in us, or excuse me, pharmaceutical companies getting interested in us, and also being able to learn from them, to be able to compare your mutation, your phenotypes, your features, and be able to talk about that. So just thank you.